Cognition and mental health in menopause. A review. Cognitive and mood changes are frequently mentioned as complaints before, during, and after menopausal transition. There is substantial biological evidence for such associations to occur, as there are many mechanisms through which estrogens can affect the brain, by regulating metabolism, increasing cerebral blood flow and dendritic outgrowth, by acting on nerve growth factors through the co-localization of receptors via neurotransmitter synthesis and turnover, and many more. However, the evidence for objective and longer-term changes in cognitive function and mental health over the menopausal transition and beyond is less clear. While hormone treatment, HT, including estrogens, could potentially reverse these psychological issues, the evidence of long-term benefit is also inconclusive. However, for women with severe menopausal complaints, and particularly for those who undergo early menopause, including women with premature ovarian insufficiency, personalized HT, at least up to the natural age of menopause around 50, should be considered, which is probably safe up to 10 years of treatment, unless contraindicated. UK Chartered Institute of Personnel and Development, CIPD research survey of 1409 working women between 45 and 55 years of age suggested that menopausal complaints most reported were hot flushes, 72%, sleep disturbances, 64%, and night sweats, 58%. A recent review of 19 studies concluded that cognitive complaints were associated not only with menopausal transition, but also with specific areas of objective cognitive decline, affecting verbal memory, attention, and working memory. However, not all studies they reviewed reported these outcomes. For instance, the review mentioned 2 neuroimaging studies where cognitive complaints were associated with medial temporal lobe functioning, which declines early in Alzheimer's disease. Our review suggested that perhaps the effects of menopausal transition were most apparent on complex cognitive tests, which could benefit from using strategies, for example, to improve recall of learned material, such as needed for word lists or for verbal fluency. The effect of the loss of sex hormones on verbal memory and executive function is possibly most pronounced in women undergoing surgical menopause, particularly if this is induced before the natural age of menopause without HT. The FMP is usually around 50-51 years of age. Compared with the gradual decline in hormone levels due to natural menopause, surgical menopause is characterized by an abrupt decline in sex steroids. Our earlier Cochrane meta-analyses have reported benefits of HT on cognition in women with dementia, but similar to that observed in middle-aged, recently menopausal women, the benefits were only seen for a couple of months of treatment and not in all studies. In contrast, in the Women's Health Initiative, WHI randomized controlled trial study, in older women, 65 years, at risk for CVD, an increased risk of dementia was seen with combination HT use, already after 1 year of treatment. Interestingly, in the KEEPS, beneficial effects of 48 months treatment with conjugated equine estrogens, but not transdermal E2, were observed in reducing anxiety and depression. However, while women who have had a previous mental health disorder may show an increased risk for depression in the perimenopausal transition, clinical depression is not generally seen to develop in women during menopausal transition. While menopausal complaints of psychological health issues, such as brain fog and depressive symptoms, are common during menopausal transition, there is less evidence for an objective long-term accelerated decline in mental health and cognitive functioning after menopause. For cognitive issues, these transient effects seem to be most pronounced on verbal memory and learning, perhaps related to some extent to a slight slowing of complex information processing speed.